So the study is a stick meta-breast, which was presented by my colleague François-Clément Bidard from Curie Institute, aimed to demonstrate the clinical utility of a circulating tumor cell in the management of metastatic breast cancer. So the idea is, for several years now, we know that detection and enumeration of circulating tumor cell is associated with prognosis in metastatic breast cancer. However, we don't have the clear evidence that having this information can help the patient management, and there is no clear demonstration of the clinical utility of CTCs in the management of breast cancer. So the aim of this study was to use this information about the prognosis of the patient to help the clinician to decide which type of treatment they should use in first-line metastatic breast cancer patient with hormonal receptor positive and HER2 negative disease. So the idea at that time was to decide between starting the treatment with hormonal treatment, as it is a recommendation for this patient in general, or to start with chemotherapy because the disease seems to be quite aggressive, and the aim was to obtain a clinical response. So it was a randomized trial which included less than 800 metastatic breast cancer patients in first line. It was run all over France. And the patients were randomized between having, in all cases, a circulating tumor cell detected in the blood. So that was the case for all the patients. And then they were randomized between having the information with of the CTC count given to the clinician, or doing the treatment and choosing the treatment between hormonal treatment and chemotherapy according to the clinical evaluation by the physician. So in the arm where the patient had the information about the level of CTC, when the level was high, the recommendation was to give chemotherapy, and when the level was low, the recommendation was to give hormonal treatment. So the first conclusion of this trial, and which was the primary aim of the study, was to show that the two arms were equivalent in terms of progression-free survival and overall survival. So that showed that clearly using just one parameter, which was CTC level, was doing as well as clinical feeling or evaluation by the physician to decide between hormonal treatment or chemotherapy for a patient. However, what was presented at this meeting this year was the update of the trial. And what was observed was the behavior of the different group of patients. We had a group of patients in this study who had a clinical evaluation saying that the disease was of good prognosis. We would call them clinical low, and which was correlated also with a low level of CTC. So this category of patients, which represented nearly 48% of all the population of the clinical trial, had a quite good outcome with overall survival around 5 years, with only monotherapy of hormonal treatment. On the other hand, we had a group of patients with high level of CTC, so we call them CTC high, and a clinical evaluation of aggressive disease, so clinical high. And this group of patients, which was a small group of patients, nearly 13% of the patients had a poor prognosis with a low overall survival. And in the middle, we had a group of patients with discordant evaluation, and specifically the group of patients with clinical evaluation of a favorable evolution of the disease. So we call them clinical low. So according to the physician, the disease was not aggressive, but we had the information that in this group of patients, the level of CTC was high. So there was this discordance. So according to the protocol, there was some patient in this situation who received chemotherapy, and another part of this group of patients who received only hormonal treatment. And so this group of patients represented around 25%, a quarter of the population. And so what we observe clearly that in this group of patients, there was a clear benefit of receiving chemotherapy compared to hormonal treatment. So, and the update of the trial clearly demonstrated that there was also a superior overall clinically significant benefit in terms of overall survival in this group of patients receiving chemotherapy, because the CTC were high, but the appearance of the disease clinically was favorable. So that was the main result of this study, showing that using CTC, you could make a better decision for the patient in terms of strategy. However, now the standard of treatment in first line of for metastatic hormonal receptor positive disease is to use a combination of CDK inhibitor and hormonal treatment. So we cannot say now that using CTC would be clearly useful in this situation, and we will not change the new standard of treatment. The clinical utility now with a new strategy, which is used in general for this disease, is no more of clear interest now. However, what we can say now is that the challenge of the discussion between and the choice between chemotherapy or a new treatment like antibody drug conjugated that could be used in this population, or to challenge the patient with the disease with a new hormonal treatment, and specifically now with the third, so this estrogen receptor degrader. The first one is fulvestrant, but there are new third developed and with some clinically evidence of benefit for the patient can be used, and some of them are used in monotherapy. So that could be an important field for the use of the CTC. Use them, for example, to help to decide between starting after progression after the first line, including CDK inhibitor. What should we do? Should we re-challenge with another hormonal treatment, or should we go directly to chemotherapy, or maybe in few years ADC? So we clearly believe that that could be a clinical utility for the CTC to use them in this type of situation for the patient. So in conclusion, with the design of the study, we think that and it was a discussion by Professor Danais, who was a discussant of this presentation, who clearly say we are nearly there for the demonstration of the clinical utility of CTC, and with a high level of evidence because it was a prospective trial, but not clearly in first line, but maybe in the other line where we need to have new biomarker to decide which patient will clearly benefit of a less aggressive treatment like hormonal treatment of new generation, or to go directly to chemotherapy because the disease is clearly aggressive, and there will be a rapid progression of the disease. So that would be what I could say about this STIC meta-breast study. And we think that there is still a lot of interest in the development of the use of CTC in the management of metastatic disease. This study was supported by an academic grant of the French government, and several centers in France participated in this study. And it's also in the field of a society which is European Liquid Biopsy Society, which is also involved, and several investigators are part of this society.